Okay, guys, we may as well start now. So hi everyone, I'm Freya. I'm one of the 6 years that are going to be teaching you today. And if you could go to the next slide, Marit, thank you. So today we'll be aiming to cover like pediatric history taking, developmental milestones, and neonatal jaundice, which Marit will hopefully cover. And then Vishal will be doing respiratory diseases, viral rashes, and a bit of fever. And then I'll be finishing fever and then doing a little bit on BLS. And then next week, next Tuesday, we have a session on acute abdomen, renal and endocrine emergencies, fluid management, genetic conditions, and also pediatric cardiology. So please do come for that as well. I'll just let you guys know that at the end of each tutor finishing their bit, there'll be like a feedback code for each specific tutor. Would be really grateful if you could fill that out. It just means that we get specific information. We can tailor the sessions better to what you guys want. So yeah, without further ado, I'll give it to Marit.
Okay, hi everyone. My name is Marit. I apologize in advance. My voice might give out because I have a bit of a cold, as we all do probably. So yeah, I'm just going to cover some. I'm just going to start with pediatric history taking. So let me know if you have any questions. I'll be monitoring the chat and try to answer the questions if you can. Okay. So pediatric history taking. I'm not going to go through the parts that you kind of already know, which is like the presenting plane, history presenting plane. I'd say the key things for children. First thing is there's a lot of the social aspects are really important. So it's always important to confirm who's in the room, the relationship to the patient, and always address both the patient and the parent. But usually you'll be getting your history from the parent usually, unless the patient's like 15, 16, kind of a bit older. Okay. In children, the systems review is quite important because basically you're trying to rule out kind of any infections all the time. Because first of all, children get a lot of infections and they can't always communicate them very well because they can't talk sometimes or that kind of thing. So it's really important to look for other signs of infection or being really unwell, like drowsiness is really important, like apathy. Ask about any rashes, ask about how they've been generally letting their growth in weight and their fever. In terms of respiratory symptoms, you want to ask about what their breathing's been like. That you want to ask them to describe it clearly to kind of determine if it's more of like a stridor, croup, or just a cough. Ask about any cyanosis because that can be quite bad. It can be a sign of respiratory or heart failure even. GI, vomiting, abdominal pain. Usually you can't kind of determine, a lot of the time you can't determine exactly where the abdominal pain is. So it's kind of important to look around for other symptoms and signs like diarrhea, constipation. And then in children, particularly the hydration status is really important. So how much have they been drinking? And you kind of want to really establish in milliliters for babies, like how much milk they've been drinking. Are they also eating solids already? How many solids are they eating? Is it less than usual? And then also in terms of hydration status is the nappies in babies a lot of the time. So you ask how many wet nappies have they been having? Is there a change in color? Like if it's a darker color, then of course they're more dehydrated. Yeah, so that's really important. And then also ask about kind of dysuria symptoms and smelliness because children in general do get a lot of UTIs. Yeah, and then I think the rest you kind of know. ENT kind of problems are also quite common in children, like earaches or tonsil problems. Okay, I'm going to talk about this in a second, and then also always ask about vaccinations. It's really good if you can to have a look at the kind of vaccination schedule on PassMed, and have a general idea of when you're supposed to have these things. So always ask if they've had them. And then past medical history as usual, drug history and allergies, and then family history, and then social history again is really important. Make sure you know exactly who's at home with the patient, if they have any other children and how they are, and always ask if social services are involved. If parents get any kind of, if parents seem upset by you asking this, you can always be like, oh, it's kind of a standard question we ask, just for formality. But I don't usually say that unless they look a bit shocked, because it comes out a bit weird sometimes. Okay, so BFGD is a little acronym, I guess, for the extra things you do for pediatric histories. So the birth is really important to get a good idea of. So you can go more detailed if they're quite young. If they're a bit older, you might not need to go as detailed, but generally always ask about any problems during the pregnancy, any problems during the birth, or did they need any help with breathing neonatally? Did they have any infections? Did they need any other treatment? And then what gestation and birth weight. And then also what kind of delivery was it? Was it a C-section, a vaginal delivery, or did any like instruments need to be used? Then you ask about feeding, like we just talked about actually, so I don't need to go through that. Stool colors might be relevant in terms of if it's pale, then that might be kind of a sign of problem with the liver. And then always ask about growth. Actually ask to see the red book, which is like this little book that they carry around and parents carry around, and basically has a kind of chart usually of the height and weight. So that's really important to know that they're growing normally. And then just generally ask if there's any developmental concerns, and if there are, then, and usually you could do a quick screen, like you could ask about are they walking, if they're 1 year old, or if are they talking, how far they were talking, can they hold things, and how are they socially. And then if there's any concerns, you might go more detailed and ask more specific questions. Okay. So here's the first question. I'll have you can just read it for a minute, and then if you know the answer, feel free to write it in the chat. Okay, if anyone knows, feel free to type it in. I'm not going to give the answer yet, but we'll come back to the answer at the end. Not at the end in a bit. So I don't know if you've seen this chart before. It's a bit daunting. You do not need to learn all of it for exams, but it's good to know the key kind of things. Oh, thank you, Tony. It's good to know the key milestones and the red flags for when you refer. So a lot of the gross motor ones are quite important to know, and they do ask about that. So sitting without support at 6 months, standing at 9 months, walking at 12, and running at 18, sort of. Here are some of the red flags. So if they can't smile at 10 weeks, if they can't sit without support at 12 months, if they can't walk by 18 months, and if they have a hand preference before 12 months, because that's a sign of cerebral palsy. And basically you refer to pediatrics for that. So the answer is D, like Tony said. At 2 years, they should know 50+ words. So definitely a lot more than mama and dada. And should be able to combine into kind of 2-word phrases. Yeah, and all the other ones are normal. I'm not going to run through it because really it's kind of a memorization thing. And like I said, start with the most important, and if you have time, you can always go back and learn more of them. Now, what causes actually developmental delay? I think the main ones UCL wants you to know about are autism and cerebral palsy. So in autism, you'll have more of a social delay. Often the children will be quite like on their own, won't play with others, won't respond to their name, even though they don't have any hearing problems. And cerebral palsy, they'll have kind of motor delays, so that maybe they can't walk, or also like tippy toe walking is a sign of cerebral palsy, or like a preference, like they said before, 12 months. Fetal alcohol syndrome spectrum disorder and kind of other genetic disorders, but usually you'll have kind of dysmorphic features on the face or something like that to show you. So I don't know if the developmental milestones problem would be the only thing. Then you can have muscular dystrophies, which can cause motor delays as well. And yeah, other genetic disorders like Down syndrome. Another thing is to remember to correct for the age up until 2 years. So for example, if a child is born 3 weeks premature, then instead of smiling at 6 weeks, they have until 9 weeks to be able to smile. Okay. Any questions about that? Okay, moving on. So here, just a bit of the difference between autism spectrum disorder and ADHD. Now, it's important to note there is some overlap. A lot of children with ADHD have some other comorbid disorder, CAMS disorder often, and a lot of children with autism also have ADHD or other mental health problems. So ADHD, it's always good to learn what it actually stands for. So attention deficit hyperactivity disorder, because the 3 main criteria are inattention, hyperactivity, and impulsivity. So the first 2 are basically in the name. And basically they have to occur in more than one setting and for at least 6 weeks or 10 weeks, I think it is. And then I think according to the NICE guidelines at that point, you can refer them to pediatrics for further assessment. It's always non-pharmacological management first. So family therapy, parent training to kind of help them manage the child, teacher training, learning support, that kind of thing. So an exam's always that first. And then if they have no other choice, you can give them methylphenidate, although it has quite a few possible side effects, so it can kind of stunt growth. So it's really important to monitor BMI, and it can also cause myocarditis. So we do an ECG to kind of look at the baseline and prevent any future problems from occurring. And if there is any problems with growth, then we go to the second line, which is atomoxetine. Okay. Then we have autism, which is, like we said, you have impaired social interaction and communication, impaired imagination, and a lot of repetitive behaviors and restricted interests. And really there's like a whole host of other kind of symptoms you can get as well, but I think these are some of the main ones that you get. But really it can be such a large combination. Treatment is really just management with a multidisciplinary team to have kind of behavioral and educational interventions, family counseling, and you might give some medical therapy to help with things like sleep or kind of like comorbid ADHD or things like that, but there's not really medications you give just for autism. Okay, so yeah, that's autism. And then chronic disorder versus oppositional defiant disorder. So ODD is usually in children, and they're a bit defiant, angry, addictive, but they're usually a lot younger. whilst conduct disorder is kind of properly established aggression towards people and authority, and usually involves a bit of criminal behavior at that point already. So that's probably more of a teenage child, if you're trying to figure out which one it is exactly. Okay, so jaundice is really common in babies. So 24 to 48 hours before after birth, well, also before 24 hours. It's never normal, so you always have to do further investigations. 2 to 14 days is usually physiological, and more than 2 weeks is often pathological. So what do I mean by physiological? So this is usually in breastfeeding babies. And basically in babies, red blood cells have a shorter lifespan, which means they break down, and when they break down, they produce bilirubin, unconjugated bilirubin, which is then brought to the liver, and in the liver, it's conjugated. So because the liver is a bit immature in babies often, it's not able to conjugate the bilirubin very quickly, and so you end up with this buildup, and then you get jaundice, which is called breast milk jaundice. Then some of the risk factors for pathological jaundice are prematurity, low birth weight, another sibling affected, a known kind of maternal fetal blood group incompatibility, or any birth trauma. Okay, so causes of pathological jaundice. So before 48 hours, it's usually kind of hemolysis, so the breakdown of red blood cells, which can be kind of due to an ABO incompatibility, rhesus hemolytic disease of the newborn, or other hemoglobinopathies like G6PD and hereditary spherocytosis, which you might remember from hematology. And then the other things that we want to look out for are the congenital infections. So I'm not really going to go through them now, but it's things like toxoplasmosis, rubella, cytomegalovirus, and then sepsis can also cause the pathological jaundice early on. So you want to screen for kind of infections. And then late pathological jaundice, which is from day 14 in term babies, but day 21 in premature babies, actually. You can get, basically you do a test, a serum test, to see it's either conjugated or unconjugated. Unconjugated causes are hypothyroidism, or kind of another hemolysis or hemorrhage. And then conjugated is kind of, again, like infections, sepsis, biliary atresia, which is a really important diagnosis to rule out, and strictures. And then you've got some kind of random diseases, but they don't usually come up, so I wouldn't really worry too much about them. And these are kind of the blood tests that you want to consider doing for someone with prolonged jaundice. So the direct antiglobulin test is for the ABO compatibility, TFTs to look for hypothyroidism, the blood film and the full blood count for hemoglobinopathies, urine MCS for infection, and again UNE and LFTs also for infection and possibly biliary atresia. Now, why is it so important to treat jaundice? So even physiological jaundice. Well, it's because bilirubin can be neurotoxic, and that can cause permanent damage. So kernicterus is what we call the clinical features of kind of a bilirubin encephalopathy. Signs would be lethargy, poor eating, hypertonicity, a shrill cry, and then they might have athetoid movements like slow movements, and deafness that can kind of cause the long-term complications. So in the management, in the community, they have this kind of transcutaneous bilirubin monitor, which the healthcare visitor uses. And if it's high, then they usually refer it, the baby to the hospital. In hospital, we do a heel prick capillary sample, and that measures the serum bilirubin. And then we use that serum bilirubin to plot it on a graph to decide if baby needs phototherapy or even exchange transfusion. So phototherapy converts the bilirubin to kind of a different form that can be excreted more easily, but it can damage the eyes, so they need eye protection. So this is the graph to plot the bilirubin on once we've had it from the heel prick. So first, we want to make sure of the right gestation. And then let's say the bilirubin was 350 and the baby is 3 days old, then that means they need phototherapy. If it's 500, then they would need a transfusion. And that's kind of how the chart works. Okay. Go ahead and read the question again. I'll give you a minute. Does anyone know the answer? Okay. I'm just going to move on then. So answer is C, blood film analysis. Oh, sorry, also. Yeah, so this is a jaundice before 48 hours. So most likely causes are kind of hemolysis due to an incompatibility, an ABO incompatibility, or a hemoglobinopathy. And so first of all, it's not A because it's definitely not normal, always abnormal if it's less than 48 hours. It's not B because we kind of want to figure out what's going on first. And that might not be the treatment for the hemoglobinopathy. It's probably not C because I don't think it's going to be, we kind of want to rule out any kind of hemoglobinopathies first. And E is kind of a cause of prolonged jaundice. So the blood film shows schistocytes, which is kind of a sign of red blood cells being broken down abnormally, and Heinz bodies. So it's probably a hemoglobinopathy. Okay. Oh yeah, here are the congenital kind of infections. It's good to know some of the key features so you can kind of figure out, especially these three. But I wouldn't worry too much about it because it's not that high yield, to be honest. But so cytomegalovirus, purpuric lesions, and sensorineural deafness. And then toxoplasmosis, chorioretinitis, and cerebral calcification. And rubella is congenital cataracts and congenital heart disease are some of the common features that they mention. And if anyone kind of mentions it on the ward, a torch screen, it can be done for pregnant women, it's done for babies, and it's basically just to screen for those kind of infections that can commonly occur or they're commonly missed in those groups and can cause quite a lot of damage. Respiratory disease. So I'm going to talk about bronchiolitis, croup, Not really going to cover viral induced wheeze and asthma here, but PASMA has quite a good summary on that. Actually, I'm not sure. Vishal might be doing that actually. Okay. So the age tells you a lot in respiratory diseases in children. So bronchiolitis is the most common lower respiratory tract infection in children. Croup is an upper respiratory tract infection and occurs kind of around 2 years as the peak. Then viral induced wheeze before 5 years. And then after 5 years, it's asthma. Viral induced wheeze is kind of symptoms of asthma before it's really asthma, and it can often some children do become asthmatic, but some children are fine after the kind of young child period. And then just as a quick side note, transient tachypnea of the newborn. It's basically when the baby's breathing really fast when they're born, and it's more common if the baby's had a C-section. Basically, you want to do kind of a full examination to make sure that they're not actually unwell and make sure they don't have a fever or anything like that, and that's usually quite reassuring. So in children, sometimes they can't tell you how unwell they are, and it's really important to look to see how bad their breathing is. So signs that they're really struggling are things like grunting, apnea, so when they stop breathing, nasal flaring, tripoding, which is when they kind of sit with their arms on a chair or something to kind of get more air. It's really important to look for chest retraction, so the intercostal, suprasternal, and diaphragmatic muscles, a tracheal tug. Yeah, also look for the cyanosis. Okay. If they're becoming cyanotic, that's quite a bad sign as well. Okay. I'll give you a minute to read this question as well. Okay. Thank you, Dr. Anka. I hope I'm saying that okay. Yes, it is palivizumab. I'm sorry, I'm terrible at saying them. Do you know why? Does anyone know why? It's okay if you don't. Yeah, so they do have a kind of possible heart disease, well, the ventricular septal defect. So I'm just going to go through what kind of the disease is. Yeah, very good. What the disease is quickly. And then I'll explain why it's pembrolizumab. So what we have here is bronchiolitis, which is, like we said, is a lower respiratory tract infection. Occurs in 1 in 3 infants under 1 year. It's most commonly caused by RSV, and the peak incidence around 3 to 6 months. So it's mostly a clinical diagnosis. If you're unsure, you can do a kind of swab for RSV, but usually it's not really done. It's usually just clinical. And it lasts around 9 days, which is quite good to know, because if someone arrives to hospital, if it's been going on for a very long time, then it's unlikely to be bronchiolitis. So it has a bit of a chrysal prodrome, a persistent dry cough, tachypnea, chest recessions, and then you might hear some wheeze and crackles and auscultation. Now, with children with bronchiolitis, the vast majority will be okay and won't have any issue. And there's a lot of children get sick very often, but it's important you kind of recognize when they need to be admitted or when they have any red flags. So If you send them home, the management's just supportive. Make sure they're hydrated, make sure they get some paracetamol from their parents, and then safety net for the parents to bring them back if they have any kind of grunting, poor feeding, nasal flaring, that kind of thing. And then you might want to consider if they're in GP, or if they're at the hospital, you might want to consider admission or referral if they have a high respiratory rate, signs of increased work with breathing, such as grunting and nasal flaring. If they're dehydrated, so for babies, it's if they have less than 50% wet nappies, so compared to their usual, or if they have a poor oral intake as well. If they have risk factors like being very young, they're premature, chronic lung disease or chronic congenital heart disease, or immunodeficiency, then you might also want to consider bringing them in earlier. Yeah. So yeah, this is just again the admission criteria, and also if their oxygen is less than 92%. Because if they have less than 92% oxygen sats, they need Optiflow, which is kind of this nasal high flow oxygen that you give to babies and children, or CPAP. And then if they're feedingless, you might give the other thing you might give them is an NG with IV fluids. And then you can discharge when they're clinically stable and maintaining saturation. So palivizumab is a monoclonal antibody that works against protects against RSV specifically, and they give it to high risk cases. So a lot of time children with congenital heart disease, like Adranka said, because they're a lot more at risk of getting it, and they can get it more severely as well. Most children do not get this injection because it's quite expensive apparently. Yeah, so differentials, kind of pneumonia. Bronchiolitis is actually a lot more common in children than pneumonia, but it's good to kind of keep an eye out. And then viral induced wheeze or an infective exacerbation of asthma. Okay. Does anyone know what this is? Yeah, nice steeple sign, very good. Yeah, croup, you've already got it. I think that's basically the one that does things. There's quite a lot of buzzwords, I think, in pediatric respiratory diseases, but that's really good to learn. So here's the steeple sign. And like you said, it's a sign of croup. It's quite funny because actually in reality, I think a lot of people with kids with croup don't actually get a chest x-ray. But if they do, I guess this is what it would look like. It's a viral upper respiratory tract infection caused by parainfluenza viruses, most commonly. And it's most common in the autumn and around children. It's for children around 2 years old. Okay. And has a prodrome of coryza, stridor, and the stridor is because the upper airway is a bit blocked, and that can cause stridor. And then this sea-like barking cough is another buzzword which you might use in exams. Worse at night, and you can also again get some general picture of kind of a struggle to breathe, like chest wall recessions, fever and hoarseness. Pardon. You give any child you suspect has croup, whether it's in GP or it's in the hospital, gets a dexamethasone PO 0.15 milligrams per kilogram. That's for every child, because just that's what the evidence says is good. They will again be admitted if they have severe features or moderate severe features, which is called, they're categorized by severity with the Wesley score. I'm not going to read them out, but here they are if you want to screenshot them. I think also if you have a general idea of what is unwell, then you don't need to learn the criteria that like rigidly. You can also admit that if they're less than 6 months, if they have upper airway abnormalities, again, like other risk factors, or if you're uncertain, because this can be confused with epiglottitis, which can be quite dangerous. A little warning here, if it's severe or you're not sure, you might want to be careful about examining the airway without an anesthetist, because if it's epiglottitis or if there's inflammation of the epiglottis, then the airway can suddenly close when examining, and at that point the patient has no airway, and that can be really scary to manage. And if it's so the treatment, if they're admitted, you can also again give humidified oxygen, and if it's very severe, then you can give an adrenaline nebulizer and high flow oxygen. Okay, that's the end of my part. Hope that wasn't too long, and if people give me some feedback, that'd be great. My name is Marit, just to remind you guys. Okay, I'll pass it over to Vishal now. And if you have any questions, feel free to type them in the group chat. No worries. Do you want to share your slides, Vishal?
Would it be right if either you or Freya could share the slides, if that's okay? Because I'm on my iPad, so I don't think I'll be able to.
Do you think you could do it, Freya? Just because I'm not sure how long I'll be able to see.
Yeah, sure.
Okay, thank you.
Okay, great.
Are the
Wait, can you
slides?
see?
I don't think I can see. Why have you put them up?
Can you see now?
I can't. Can other people see the slides? Ah, there you go. Now I can see it. Thank you.
Is it
Okay, so I'll try and be quick because I know it's quite late. So just following on from what Marit was talking about, stridor, obviously the noise stridor refers to the inspiratory noise caused by extrathoracic airway obstruction. So croup is one of those causes in children, and another significantly rarer cause of stridor in children is acute epiglottitis, which specifically refers to a bacterial infection of the epiglottis, most commonly caused by Haemophilus influenza. And the reason it's quite rare now is because of the vaccination program. So you're very unlikely to see this in your placements. Whereas by comparison, you'll see croup, or you'll see at least one or a few cases of it during the 6 weeks. And the way that the two differ, particularly because croup is a viral infection, it has a lower grade fever, so usually below 39, whereas epiglottitis is a bacterial infection, so has a higher fever above 39 degrees, and the child will appear significantly more unwell. The textbooks describe this toxic looking appearance where they adopt this tripod appearance to lean forward to allow them to breathe, and they drool, so they hypersalivate because they're not able to swallow their own saliva. And you'll see elevated white cells on the bloods as well. And other differential diagnoses for croup or for stridor, here in the bottom right, a few of them are quite rare. So laryngomalacia, and inhaled foreign bodies, and bacterial tracheitis, which kind of produces this sort of mucopurulent sputum, which you wouldn't expect to see in croup. So I think that covers that. We can go into the next slide. That's okay. Okay, so we've got an SBA of a 12-month-old baby girl who's presented with bouts of coughing that end in her vomiting, 2-week history of runny nose with a decreased appetite and incomplete immunization record. So what do you guys think the answer is? I'll give you just a little bit to give an answer. Any ideas? Has an answer come through? Yeah, A. Yeah, A. So if we go on to the next slide, I think it will show answer. Yeah, so you can see the answer is A, and I think the next slide will show the guideline that we use. So the diagnosis in this case is whooping cough, which we have another slide on. And generally for whooping cough, the guidelines state that we prescribe an antibiotic if the onset of the cough specifically was within the previous 21 days, so within 3 weeks. And we choose a macrolide antibiotic, and that's usually azithromycin or clarithromycin, or in pregnant women, we can give erythromycin, which reduces the risk of it transmitting to the newborn child. And if we just go on to the next slide, which has everything on whooping cough. So whooping cough is caused by Bordetella pertussis. So it's a bacteria that infects the lower respiratory tract, and generally affects infants. And the reason that the 21 days comes from is because actually the antibiotics don't actually improve the symptoms for the patient. What they do is they reduce the transmission of pertussis to other people, to other individuals. And the reason that it's 21 days is because actually it's only within 21 days from the onset of the cough that whooping cough is contagious. So there's only any benefit to giving antibiotics if you give it within the first 21 days. And then it takes about 2 days after giving antibiotics for it to be infectious. So essentially, whooping cough is only contagious 21 days from the onset of the cough or 2 days after starting antibiotics. So I hope that's sort of clear. And it has this typical, quite long course of the illness, starting with a catarrhal phase, which is sort of the coryzal symptoms that were described in the SBA, sort of runny nose, cough, cold kind of symptoms. And then a paroxysmal phase where you get these very characteristic spasmodic bursts of coughing. So the word tussis is actually just Latin for cough. So this bacteria causes such a characteristic cough that it's named after it. And there's also this inspiratory whoop as the child tries to breathe in and catch their breath after coughing so much. And it can be particularly bad at night and also after feeding. And it can be so bad that it causes the child to vomit, which is what we call post-tussive vomiting, which is another characteristic feature that you can expect to see in exam questions that often comes up. And then finally, after the paroxysmal phase, you get a convalescent phase, which can last up to 3 months. So this is quite a long illness, and it's diagnosed clinically. But the best way in terms of what test to run, the most sensitive test is a nasal swab culture, so PCR. And the bloods will characteristically show a lymphocytosis. And the reason why that's emphasized is because bacterial infections typically won't cause a lymphocytosis, they will cause a neutrophilia, whereas whooping cough is quite unusual because even though it's a bacterial infection, it characteristically causes this increase in lymphocytes. And the chest will typically be clear on a chest x-ray, but you'll be unlikely to do a chest x-ray in children generally because of the radiation exposure. So you'd only do a chest x-ray if you absolutely had to. The reason that it's also quite rare as well nowadays, it's not that commonly seen, is because of the immunization program. But the immunization program, it's estimated that it offers protection for about 10 years after the vaccine. So it's not a lifelong protection. And yeah, we would give macrolide antibiotics, exclude them from school because of the infectious period, unless it's two days after antibiotics or 3 weeks from symptoms. It's notifiable to Public Health England. And the final thing to mention is that the complications are related to the fact that because they cough so much, they get hypoxic or they cough so much and it increases intracranial pressure, which causes rarely CNS hemorrhages or subconjunctival hemorrhages, or even anoxic seizures, rectal and rectal prolapse. So we can just go on to the next slide now. So this condition is a lot more common. So we've got a child with asthma, and these are his observations. What is the severity of his asthma attack? If you guys could just take a moment to answer that. Yeah, D. And could anyone tell me specifically why they think it's so the SATs? So did you pick severe or life-threatening then for this? Okay, yeah. So the SATs are concerning, the 90%. But the answer for this question would be a severe asthma attack rather than a life-threatening one. And we can go on to the next slide. So low oxygen SATs is a feature of both a severe and life-threatening asthma attack. I believe the key differentiators for life-threatening will be if the peak flow is silent chest, which suggests that the child's getting tired, which is why the breathing slows down and the wheeze isn't as prominent. So a lot of these features of risk stratifying asthma have a lot of overlap with the adult asthma criteria. The key differences are in the respiratory rate and the heart rate, because these observations, these normal reference ranges, are different in children. And I think it would be unlikely that you'd be expected to remember all of the individual different reference ranges for respiratory rate and heart rate, but have an appreciation for the fact that they are different in children, and that generally heart rate can be much higher, particularly in under 5. So in adults, we get concerned in asthma if the heart rate is above 115, but in children, if they're over 5, it's 125. And if they're under 5, it can be up to 140 before it becomes concerning. So you can read that slide in more detail, and it's worth learning the severity criteria. So if we go to the next slide. Yeah. Oh. Yeah, so it'd be a severe asthma attack. So yeah, that's fine. We can go into the next one. Okay, so how we manage acute asthma in children. So you can do an A2E assessment essentially for this. And so if their oxygen stats are low, like in this question that we had in this STEM, we would give high flow oxygen, aiming for 94 to 98. And the oral prednisolone we give for all asthma exacerbations in the same way that we do for adult asthma for up to 3 to 5 days. And the way that we manage asthma, so we start by just giving salbutamol via an inhaler, a metered dose inhaler with a spacer. And a child will be admitted if they've had 10 puffs of that and it's still not improved the symptoms. And then that's when we'll give nebulized salbutamol and ipratropium, which will be driven with oxygen in the nebulizer. And if that doesn't work, then we can add more third-line drugs. So magnesium sulfate is a drug that can help reduce the airway inflammation. And if, again, that doesn't respond, if the symptoms don't respond to that, you can start thinking about IV infusions of salbutamol, aminophylline, or magnesium sulfate. But all of these are quite senior-led decisions. And I think knowing points 1, 2, and 3 in good detail is very key, because as a junior doctor, that would be our main role. And the infusions and the later parts of the management would be definitely at the point where you're calling in seniors. And what I would also say is that asthma exacerbations are incredibly common in terms of child A&E admissions. If you spend time in placement, you will see children with asthma almost guaranteed. There are several admissions every evening, and it's one that you should know in a lot of detail, because it's definitely a core condition. So we can go to the next slide. Yeah, and then this is how we decide whether a child is okay to be discharged from hospital after an exacerbation. So we'd want them to be stable on their usual inhaled bronchodilators, so off nebulizers and onto their inhalers. And they want to have a peak flow above 75% of their predicted, and obviously normal oxygen saturations. And before they leave, these are the key jobs that need to be done that a junior doctor would largely be responsible for making sure happen. So they need to check the inhaler technique, send them home on prednisolone for 3 to 5 days, give a follow-up with the GP within 2 days, and a specialist pediatric asthma clinic within 1 to 2 months. And every child with asthma will have a personalized asthma action plan. Yeah, those are the key things to remember for that. And I think it's worth also noting before we finish with asthma that the diagnostic tests for asthma, the objective tests, which are spirometry and with the bronchodilator reversibility, and the FeNO, fractional exhaled nitric oxide, both of those objective tests that we use in adults are not accurate in children below the age of 5 years old. So below the age of 5, we wouldn't do spirometry or FeNO. We'd diagnose asthma symptoms clinically. And above the age of 5, then those tests become more accurate. So that's just an important thing to know about how we diagnose asthma in children as well, because it's much more challenging than it is in adults. Okay, so we can go to the next slide. Yeah, so now there's this next question of a 10-year-old boy with a rash. So I'll leave you guys to answer that. B. Yeah. So people putting B for measles, which is right. So the reason that we suspect this is measles is because the rash that we're seeing is a characteristic maculopapular rash. So maculopapular, the name refers to macules, which are flat red patches, and papula, which refers to the tiny raised bumps. So maculopapular is a red rash with lots of bumps as well over the rash. And both measles and rubella and mumps can cause maculopapular rashes, but in exam questions, the way that you can tell that whether it's either of those is through the other characteristic signs. So in this case, the rash originated behind the ears, and the picture shows conjunctivitis, which is a classic complication of measles. So that's the reason that measles, and another big giveaway in this is the incomplete vaccination history, which is one of the main reasons that you might end up seeing a child with this, because otherwise it's quite rare. The only reason that a child would have this is if they didn't have their MMR vaccination. And this picture in the bottom right shows Koplik spots, which are the characteristic spots on the buccal mucosa that you get in measles, which are pathognomic for the condition too. So we can go on to the next slide. Yeah, so this is quite a good table summary of all the different viral exanthems. So the word exanthem just refers to a widespread red rash, which can have a number of causes, whether that's a toxin or a drug, or in this case, a virus. So there are lots of different viral exanthem in children that are worth knowing about. And the way, for good exam technique, you need to know the key ways of differentiating the two. So for between measles and rubella, rubella has the suboccipital and postauricular lymph node swelling, whereas in measles, you'd expect to see that the rash originates behind the ear, and you get sort of characteristic complications from measles as well. So in measles, the common ones are otitis media, pneumonia, and very rarely a type of infection called subacute sclerosing panencephalitis, which is a very slowly progressive brain infection, which is unlikely to come up, but has come up in UCL lectures. So it's worth being aware it exists. And then the other ones to be aware of are chickenpox, of course, are caused by varicella zoster virus. So this causes that typical vesicular rashes that's widespread. And it's worth knowing that children can be infectious before the rash appears, so 1 to 2 days before the rash, and they're infectious until all the vesicles, until all the blisters have dried up. So they need to be excluded from school until all the lesions have crusted over. And the final two that we're going to talk about is roseola infantum, which has a characteristic pattern where the fever appears before the rash, which is quite unusual, and then 5 days after the fever, the rash appears. And then you also get these small raised pink spots, which affect the trunk, the palate, and the uvula, which are called Nagayama spots, and that's managed conservatively. And then erythema infectiosum is a slapped cheek syndrome caused by parvovirus B19, which was where you get sort of firm red cheeks as if a child had been slapped. And also parvovirus can cause aplastic anemia if it in immunosuppressed children as well. So we can go on to the next slide. So fever. So yeah. So fever is probably the most common presenting complaint in pediatrics, and it has a huge differential. And there are lots of different ways of approaching this topic. one of the ways that you can approach it is sort of through this slide. The way that it's done is the characteristic infections that affect only children, or most commonly only children, which is in the box on the left, which includes those viral exanthem rashes we talked about. And you can also categorize it by major infections. So these are infections that carry significant morbidity and mortality if they're not treated promptly. So this includes things like meningitis, which we'll talk about later, pneumonia, which is quite rare in children but can still happen. And another important thing to know about pneumonia in children is because the signs of sort of difficulty breathing are quite difficult to elicit in children. Pneumonia can also present with abdominal pain in children because the lungs are quite low down and the child's quite small. So it's sort of a rare sort of way of eliciting that as well. So it's worth being aware that pneumonia can present as abdominal pain in children. A lower lobe pneumonia, that is. And then UTI, pyelonephritis, septic arthritis, osteomyelitis. So almost all different bodily systems, and then rarely malaria, TB, and then CMV, HIV. And then there's the minor infections, which are incredibly common. So upper respiratory tract infections like bronchiolitis, croup, and then just general common colds and flu in children are very common. Gastroenteritis is very common as well, as is otitis media and tonsillitis, both viral and bacterial causes, most commonly viral tonsillitis. And then there's malignancy, which can cause a fever. So that can be either leukemia or lymphoma. And then there's the autoimmune conditions like Kawasaki's, which we suspect in a long-standing fever, longer than 5 days. So we can go on to the next slide now. So this is quite a busy slide, but I think what you can take away from this is that you can just sort of think if a child presents with fever, let's do a top-to-toe assessment of what could possibly be causing the fever. So what's the infective source? So it could be something in the brain. So that's why you start from the top with meningitis and encephalitis, down to the throat. So pharyngitis, upper respiratory tract, the ears, otitis media, and then you've got sort of the heart. So from infective endocarditis, the lungs, and then the bowels from gastroenteritis, the bladder for UTIs, and then down to the bones for osteomyelitis and the knees for septic arthritis. So you can read that, I guess, in your own time if we send the slides. We can go to the next slide. And what this diagram is trying to show is essentially out of all the serious feverish illnesses in children, which of those serious illnesses are more common and which are quite rare. So the serious ones to know about are UTI, pneumonia, and the skin soft tissue infections, because these are quite common and can be quite serious in children. And then the really rare ones are here at the bottom, so meningococcal disease, meningitis, septic arthritis, and Kawasaki. But they do come up quite often in exams, so it's worth knowing about them, of course. So we go to the next slide. So yeah, so this is the approach to the febrile child. So NICE have very useful guidelines about how to stratify if a child is sort of severely unwell, based on various signs we'll go over in the next slide. But essentially what you want to do when you investigate a child with a fever is identify if there's a way that you can find the infective source. So you can do that by first trying to elicit any clinical signs, but they're very difficult in young children. So for meningitis, you may get the classic sort of neck stiffness and Brodzinski sign, but again, in children, these are quite difficult to see. And septic joints, so you'd get a swollen joint, but often the pain from a septic arthritis can radiate. So a child might just present with limping as well. And then there's otitis media. So again, a child might not be able to tell you that they're having pain in the ear. They might just be crying and irritable. The same with tonsillitis and even the pneumonia or a UTI. And then how long they've had the fever. So as we said, for longer than 5 days, we think about Kawasaki's, but also rarely TB, malignancy, and autoimmune diseases. So we can go to the next slide. So yeah, here we go. This is another question I'll let you guys answer. Yeah. Yeah, so the answer for this would be a weak cry. And the reason that's the most concerning feature is that's what is listed on the NICE traffic light system. So quite a few of these features in the answer here are actually quite concerning, but the most concerning feature would be the weak cry. So if we go to the next slide, it shows the traffic light system. Yeah. So this is worth knowing about. I know it's quite a lot of information, but it's worth knowing the key features about what makes a child high risk, intermediate, and low risk. So the key ones to know for high risk are, like we said, the weak cry, but also reduced skin turgor, and if they just appear ill to any healthcare professional, such as a pediatrician, and also things like non-blanching rash, a bulging fontanelle, neck stiffness, any focal neurology or seizures, and grunting, tachypnea, so and the moderate or severe chest indrawing. So those are the recessions. So you can get intercostal and subcostal recessions as a marker of severe respiratory distress. And then the intermediate risks are things like poor feeding, reduced urine output, and then no smile, essentially, or if a parent is concerned. And these are the ways of risk stratifying children that present with fever, because it's that common, and knowing whether they can be managed in the community or whether they need to be seen by a senior pediatrician that same day. So we can go on to the next slide. Yeah, so this is quite good. It kind of summarizes the high risk features. So like we went over already. Yeah, so this is the next question. Yeah, any ideas? Okay, should we go on to the next? Yeah, so the answer in this case is D, IV amoxicillin and cefotaxime. And the reason that is because we're suspecting bacterial meningitis in this child. So we need to give them antibiotics. And because they are younger than the age of 3 months, we give amoxicillin to cover for listeria, because a listeria meningitis is more common in extremely young neonates, so below the age of 3 months, and also in the elderly or anyone immunocompromised. So if we go on to the next slide. So meningitis is a really important condition to know about for pediatrics as well, because a failure to promptly recognize and treat it can not only result in death, but also permanent brain damage, so sensory neural hearing loss, but also lower IQ, and in the immediate postnatal period can cause cerebral palsy as well. So it's important to be aware of this diagnosis, despite how generally rare it is because of the vaccination program. And the signs for meningitis would be irritability, reduced feeding, a bulging anterior fontanelle specifically, and neck stiffness and photophobia and seizures, and then the non-blanching rash, which you can see in the far right. So the signs of raised intracranial pressure are worth knowing about, because this would be a suggestive very severe meningeal infection. This would be lowered consciousness, any kind of focal neurology, so that would be limb weakness, vision changes, hearing changes, or papilledema, which is swelling of the optic discs. And then the causes, the pathogens that cause meningitis. In neonates, the 3 most common to know about are group B strep, E. coli, Neisseria, and then in older children, it's Neisseria meningitidis, strep pneumoniae, which are both bacteria that live in the upper respiratory tract and ascend up to the meninges to cause the infection. And this rash on the right, it shows a non-blanching rash, and it's worth knowing other differentials for non-blanching rash in children, because it's one of the core presentations to know in pediatrics. So for instance, a non-blanching rash could also mean other conditions like Henoch-Schönlein purpura, immune thrombocytopenic purpura, or even a presentation of a leukemia, or quite rarely it can be a presentation of non-accidental injury as well. So a non-blanching rash doesn't always imply meningitis. So if we go to the next slide. So we have to investigate. So a child with a fever might have meningitis, but might not be obvious. So we might do a lumbar puncture to rule it out in infants that are younger than 1 month with a fever. So any infant younger than a month old with fever, or 1 to 3 months who have raised white cells and appear unwell. And remember, an LP is contraindicated if there's any signs of raised ICP. And the way we manage it is broad spectrum antibiotics. So in a GP setting, that would be iron benzyl penicillin at first, then refer them to hospital. In the hospital setting, it would either be cefotaxime with amoxicillin if they're under 3 months to cover for listeria, or if they're over 3 months, ceftriaxone. And we give dexamethasone unless they're below the age of 3 months or in septic shock, because the dexamethasone is believed to reduce the neurological sequelae from the infection, so reduce the risk of hearing loss and other problems, brain damage. So we also have to give prophylaxis for close contacts, so parents or siblings or anyone in the school, for instance. So that'd be ciprofloxacin or rifampicin. If we go to the next slide. So this is quite a good summary slide that just shows the sort of key features in the history in meningitis, the examination findings that we talked about. So the purpuric rash, neck stiffness, the bulging fontanelle, this rare manifestation of the disease called opisthetotonus, which is when a baby sort of has this dystonic arching of the back, so their whole body arches backwards because of the infection. And the investigations that you would do is a full septic screen, so you do an FBC with the white cell differential, you do a blood gas, you do a coag screen because of the complications of DIC that you get with meningitis, CRPs, knees, LFTs, blood culture, throat swab, and then you take samples. So you do a lumbar puncture as well, unless it's contraindicated, which we'll go on to talk a bit more about the other contraindications for LP. And if it's TB, you can, which is quite rare, I suppose, generally, but especially in children, you could do a chest X-ray, an IGRA or MANTU test. And yeah, you'd consider a CT or an MRI brain scan, especially if you're suspecting an encephalitis as well as a meningitis. So we'll go on to the next slide. So these are the key contraindications to an LP. So if they have focal neurological signs or signs of raised ICP, they have a coagulopathy or thrombocytopenia because of the risk of an epidural hematoma. So if they inject the needle to do the LP, and then because of the lack of platelets, blood builds up behind the spine and can cause a cord compression. So it's worth to everyone before an LP needs an INR done as well. So we can go to the next slide for that, and then after that. And then these are worth knowing about for exams as well. So the biochemistry of CSF in meningitis and the different causative agents. So for bacterial, so all of this kind of overlaps. So basically it's identical to what it is in adults in meningitis as well. So you might be familiar with a lot of this from 4th year. It's worth being aware, for instance, of the fact that, for example, Listeria and Neisseria meningitis are both bacteria. So biochemically, they'll appear the same if you do a CSF analysis. But then how do you know if it's Listeria meningitis or if it's meningococcal meningitis? And the way that you can know is because they also do microscopy on a CSF sample. And microscopy would show that Neisseria meningitis is gram-negative diplococci, whereas Listeria is gram-positive rods. And that's come up in a UCL question on Moodle before, so it's worth being aware that there are ways to differentiate between the different types of bacteria, and that would be through gram stain and microscopy. But yeah, we can go to the next slide. And that's the end of my bit, so I appreciate any feedback. And then I'll hand you over to Freya as well. But thank you so much for your time, and hope you enjoy your placement.
Okay, guys, we can move on to the last bit. Hopefully we'll finish with lots of time to spare. So we're starting off with a question. Just put it on the chat when you know the answer. Okay, so yeah, the first thing you'd want to do in any seizure is to start your AT algorithm, and the first thing you do for that is starting the clock. So yeah, and then moving on to this question. If you're not sure, you can just guess. I literally don't mind. Okay, it's fine. We can just go through it. So the answer is A, and this is asking for which of these is incorrect about febrile seizures. So if you go through it, the risk of progression to epilepsy, yep, that is true. It is about 3%. It does usually occur between 6 months and 5 years of age. You should try a cold bath to lower temperature, and you should be trained to use benzodiazepine if it does reoccur. Using paracetamol, a lot of parents think that using paracetamol is fine because I feel like they may have not had it explained to them, and they just think, oh, it's just like any other fever, so it should work. But it actually doesn't control the temperature, and you can't reduce the risk of reoccurrence. And sometimes giving paracetamol is kind of associated with even more reoccurrence for some reason, but we're not exactly sure why. Okay, so febrile seizures, one of the common reasons a child would come in if they have a fever, and it's basically like the name says, it's a seizure provoked by fever, and it's normally due to a viral infection, and they normally have a background that's like healthy, they haven't had any conditions. There are two types of febrile seizures, which we'll cover in a bit. Actually, I think we'll cover that first and then we'll come back to this slide. So you can have a simple febrile seizure or a complex one. So a simple, like the name suggests, is a seizure that lasts less than 15 minutes. It's usually tonic-clonic, and the person, like the baby, would have recovered within like an hour. Whereas a complex febrile seizure lasts greater than 15 minutes, and it's usually a focal seizure, and they may have repeat seizures within 24 hours or during the same like illness period. And something that just to remember when you're thinking about the type of seizure that they're having, it's obviously really important to ask that question if someone's come in with a febrile seizure. But just remember that if they have a background of like epilepsy or any neurodevelopmental conditions, they may already have seizures often, and that they could be a specific type of seizure. And on top of that, if they're having febrile seizures, it could present in the same way. So it doesn't necessarily mean that it has to be like a tonic-clonic seizure if it's simple. If it's the other two things and it's like a focal seizure, it can still be considered a simple seizure. So that's just something to keep in mind. And then, yep, so we've already covered all of this. Like we covered with the first question, if the seizure lasts greater than 5 minutes, because you've started timing it, it's important to call an ambulance. And you would admit the child if it was their first febrile seizure or if they have any signs of like a complex seizure. And in terms of prognosis, so this is something that's really commonly tested on in OSCEs, because it's quite a difficult station, but a really good explaining station to do. So it's just, I think you just need to learn these things, but about 1 in 3 will experience further febrile seizures. And the risk of you experiencing more febrile seizures within the same episode is, for example, if they were complex compared to simple, if your fever was recorded at less than 39 degrees, but because that basically means that your threshold for having a seizure is at a lower temperature, so you're at a higher risk of getting them again. And also if the seizure started very soon after your temperature rose, that basically means that you couldn't handle the temperature spike. And the whole reason febrile seizures are proposed to happen is because your temperature spikes really quickly, and then your brain can't keep up with regulating the temperature spike. So then it can start seizing and cause these issues. So that's the risk of you getting another febrile seizure. The risk of it turning into epilepsy. So the general background risk is about 1% in the population. It's about 2.5 to 3% if you have had experienced febrile seizures, and the risk increases when you look at these three factors. So if the person has been suffering with complex seizures, if they have a background of neurodevelopmental conditions, or if the seizure can lead to like status epilepticus. So these three things can increase the risk of it turning into epilepsy in the future, and it can increase the risk up to like 50%. So it can be quite big in those people, but for the vast majority of babies, the risk is about 2.5 to 3%. And then this is just a seizure algorithm. So it's very similar to a normal seizure in adults, but the doses are slightly different. So once your seizure starts, obviously you would time, and then you do airways, breathing and circulation, and you give oxygen. And then it's obviously really important to check glucose in your D for disability. And then depending on where you are, if you're not in hospital, you can give buccal midazolam. If you are in hospital, you can give IV lorazepam. And then if that doesn't work, you can give another bolus of IV lorazepam. And if that doesn't work, you can give phenytoin, but I think hospitals' guidelines are slightly changing to prefer Keppra over phenytoin. And then if none of these drugs have worked, then you would consider like inducing, but that's obviously very severe. And something to remember that what they use often. So if you are in like peds resus and there's like a call coming in for like a child who has been seizing for the past 10 minutes and they're about 5 minutes away, something that nurses or pediatricians would prepare is something called wet flag. So that's basically all their important calculations. So it's like based off their weight, and there's like a formula for that. And then it also looks at like their general like energy expenditure, and then like their fluids and their lorazepam dose and all of that. And they would have that ready so that when the patient comes into resus, that's good to go. So if you see wet flag, it's just know it's for like really emergency situations. And then in terms of the overall management, like what would you tell someone's, like the patient's parents, if they've come in with a seizure, is just to kind of monitor the child, make sure that they're kind of kept in as safe of a space as you can keep them. So try to put a cushion around them, or make sure that they're on the floor, and yeah, time it. And then like you can give them benzodiazepines if they've had febrile seizures in the past before. Then you can start giving them, and you can tell them how to use them. And then it's just really, really important to obviously safety net. So if it turns into status, then call 999. You'd call them anyway if it lasts more than 5 minutes. And then if the baby previously appeared confused or lethargic, and then this I actually ended up seeing this year in placement, but the baby turned like pale, and was cyanosed at the lips and peripherally, and then she had like purple mottling of her skin on her arms and her legs. So that's obviously very concerning, because it means that there may be something else going on, like a cardio thing as well. Potentially like a mix of like breath holding spells with febrile seizures. So obviously you'd warn the parents about that. And then also if they have like a non-blanching rash, again could indicate a background of a viral meningitis. And then just for SBAs, just remember to consider other seizure or epileptic conditions like West syndrome and tuberous sclerosis. Okay, so moving on to UTI. So this is really common in kids, just as it's common in adults and literally every other demographic. So you should always consider it in the fever of unknown in children, because like in the elderly patients as well, it can present really non-specifically. As you can see, the signs of UTI in young children are really kind of vague. And most of them may not even present with any of this. It could just be that they've run a little bit of a fever and the parents have come in worried, and you've ruled out like an ear infection, a throat infection, the chest sounds clear, and then you could be thinking, oh, maybe it's a UTI. So we'll go through how to do a clean and catch urine sample on the next slide. And then it does say here that you can use a dipstick as normal, but what I got taught was that if the child is over the age of 2, then you should be able to use dipsticks as normal because you're assuming that they're not wearing a nappy. However, if they're younger than the age of 2, the way that dipsticks worked for a urine infection is that they pick up like nitrites. And the way nitrites form is they actually form when there's urine, it's sitting in the bladder. Um, and if the urine's not going to be sat in the bladder because under 2 you're wearing a nappy, so you're going to be incontinent, you're not going to be able to pick up nitrites or create them. So the bacteria is not going to be able to do that. And therefore, a lot of UTIs will be missed if you're just doing a urine dip and not doing a culture. So I think if they're under 2, it's probably good to do a culture just in case. You can get them quite easily as well if they're wearing a nappy, like a clean and catch. And yeah, if you do a culture, if there are like atypical signs or if it's like a recurrent infection, and we'll go through that in later. In terms of the management, it's same as adults. You recommend trimethoprim or nitrofurantoin. And it's just a 3-day course as well. If they're under the age of 3 months, you'd want to refer them to pediatric specialists. And the reason you do that is because you'd be worried that there's like an underlying like anatomical abnormality that's been causing them to have an infection, and we'll go through this later as well. And just remember that some patients may already be on may already be on prophylactic antibiotics, and they could be presenting with another case of like UTI because their prophylactic antibiotics haven't worked. And in this case, you'd also refer them because you don't know exactly what antibiotic to use. So this is basically what a clean and catch is. You just rub this area where underneath there would be their bladder, and hopefully it would be like somewhat full so that some stimulation will cause them to pee. The hardest part about this is just making sure they don't pee on you. Yeah, so this is the next question. It's okay if you like unsure, just guess something so I know you're all still here. Okay, so this I thought was a really hard question. I probably wouldn't have got it at your stage. But it's actually Klebsiella grown on culture. So I'll go through all the options. So this being their second episode of a lower UTI within 6 months. So that is not considered like a recurrent infection. There is like certain rules for recurrent infection, which we'll go through later, and then you'll understand. Fever of 38 during acute illness. Now, I'm a bit skeptical of this because I think a fever of 38 is decently high. It doesn't indicate necessarily serious illness, but it could indicate like an upper UTI, like pyelonephritis, for example. And in that case, you would require further investigation. But I think it could be because it's a fever of 38 and higher, not actually of just 38, which I think is quite mean. One episode of vomiting during illness, this doesn't necessarily indicate serious illness. Um, Kids vomit for all sorts of reasons. And then still feeling unwell on day 2 of antibiotics. Again, this is worded a bit weirdly, like their second day of antibiotics hasn't necessarily finished, so they haven't been on antibiotics for 48 hours. So if they're still unwell 48 hours after starting antibiotics, at that point you'd be a bit concerned and they'd need further investigation. And then Klebsiella grown on culture is the correct answer because the normal like organisms that cause infections in children are E. coli, just like adults, Proteus, and that's a bit rogue, but I just remember Proteus for like kidney, like a specific type of kidney stone as well. And then also Pseudomonas. And then Klebsiella isn't one of those three, so it's considered a bit like, why is it there? And then yeah, so what is an atypical UTI? So your best bet is to use like the traffic light. Anytime a child has got a fever, just use, or is ill in any way and you're confused, just use the traffic light system. That's what I did. So all these things, so an abdo or bladder mass, you could be potentially thinking of like, oh, could it be like a nephro or neuroblastoma? That's a bit weird. Or is it like pyelonephritis, or is it like also more like kidney disease and stuff like that? Like why? Like that's a bit concerning. And then these signs, so obviously septicemia, you'd be worried about sepsis. And then yeah, failure to respond with E. coli and infection with non-E. coli organisms. So yeah, I guess even if you don't have, even if you're Proteus or Pseudomonas, and you'd still consider that an atypical UTI. And then recurrent UTI is when you have two or more upper UTIs. So that's like two or more episodes of pyelonephritis, which is quite a bit. One upper and one lower, or three or more lower. So the best way to remember this is that you need more of the lower ones compared to the upper ones, because lower UTIs are way more common than upper UTIs. But yeah, so why do we need to investigate some UTIs? So this is a really niche part of peds, but I saw it a lot during my placement, and it was vesicoureteric reflux. So what that essentially is like the junction of like the junction's a bit weirdly angled, and it means that urine ends up going back and there's like a backflow of urine. And this essentially means that it's at a higher risk of infection. And it also means that as urine is backflowing, it presents quite often as like issues with the kidney, because the urine is backflowing, there's more like urine in the kidney, and the pressure in the kidney builds up and it can't filter that well, and it causes lots of issues. So the way to kind of pick this up is with Damsa scan. So this looks at kidney scarring. So this is seen on this image on the right here, like it kind of looks like a weird ghost, but that's really just your kidneys and your bladder. And the way I remember that this is Damsa is because Damsa is looking at scarring and like texture, and this is like really weirdly textured. I don't know if that helps you, but that's what I used anyway. And then NCUG is to look at the actual reflux. So that's seen on the left here, and you can see that there is like, you can like see the urine kind of traveling. They might even sometimes they have like a catheter in, and then they will remove like some urine to see the flow of urine. So that's really looking for obstructions. But most likely they won't do that. And you can just see if there is an obstruction or not in like the filling and the voiding and stuff. So yeah, that's really important. Okay, next question. Yep, perfect. So you have picked up that this could be potentially Kawasaki's disease. And in that case, it's really important to do an echo to rule out, or to kind of not rule out necessarily, but to make sure that it doesn't develop into like a coronary artery aneurysm, which is what you're most worried about, because that's the biggest cause of death in kids with Kawasaki's disease. Okay, so how these are the symptoms of Kawasaki's disease. The way I always remembered it was crash and burn, which sounds awful, but it's really useful. So C is for like conjunctival injection, or basically just means redness in the eye. R is for rash, which is a bit like general. It's not like a specific rash. And then A is for adenopathy, so that's like your lymph node swelling. And then S is for strawberry tongue. And you can also remember the correct like dry lips as well associated with that, but I definitely didn't do that. And then your H is for your hands and your feet. So these can often be like red and swollen, and towards later stages, there can also be peeling of the skin, and that's sometimes called desquamation. So this graph really goes through, oh, and burn. I forgot burn. The most important one is burn, and that basically means fever. And it's usually when the fever's lasted greater than 5 days. In all the things we've gone through so far, other than maybe like cancer, which we'll cover later, the fever doesn't usually last greater than 5 days in all your viral infections and stuff. But in this, the fever does last quite a while. As you can see from this graph, it can last up until like the 4th week. And then the way that it presents in, so not all these symptoms have to be present in each person. As soon as a kid's fever lasts greater than 5 days, I think in a lot of like hospitals and pediatric centers, they will activate like the Kawasaki protocol, and they'll get an echo done on the kid because they don't want to miss this, because obviously it's very severe and fatal. So like the signature thing to remember Kawasaki's disease is the fever greater than 5 days, and it also helped me differentiate Kawasaki's from the rest of these differentials, like scarlet fever, which is the one I got confused with the most because of the strawberry tongue. And then in terms of investigation, you can't pick it up necessarily, but you can rule it out by ruling out all these other differentials, or as many of them as you can. And then Kawasaki's has like 3 stages, so it's kind of seen here. I didn't like learn them properly, and I don't think you need to necessarily, but what you do need to know is that it's managed with aspirin, and that's really rare, and it's the only case of like pediatric condition that's managed with aspirin, because aspirin is associated with Ray's disease, which is this. I don't think they'll ever ask you what Ray's disease is, but if they did, now you know. And it's also managed with IVIG. And yeah, and you give aspirin, by the way, to prevent the coronary artery aneurysm. And the reason why that happens is apparently to do with like, because this is like a weird disease. It's like a vasculitis, and it causes inflammation of the vessels, and this ends up leading to a higher risk of having coronary artery aneurysms. Okay, I think these are one of your last questions. Yeah, perfect. So ALL. The reason we can quickly go through what may not be the others. So the things that's really concerning here is, well, the 2-week long history of lethargy. It sounds like it's not that long, but in a 5-year-old child who will normally be really active and be like jumping off walls, that is quite a long time if they're feeling quite fatigued and they can't do anything. And then the fever is only for the past 3 days, but it could be they could have had like an underlying fever as well. So just remember that maybe the mum might or the dad might have not picked up. And then they've got this rash and they appear pale. So the pale is kind of indicating like is making you think, oh, anemia, and the rash is kind of making you think, oh, maybe there's like some sort of platelet issue or like bleeding issue, and that should make you think of cancer. And well, it's not malaria. There isn't any really mention of like a travel history, AML, wrong age group, so it'd be in people who are normally older. EBV, it could be EBV, but it doesn't really present with what it does, but like the age group's also wrong, and I'd be more worried about ALL. And then juvenile idiopathic arthritis, it kind of has similar symptoms, but you haven't mentioned joint pain, which is the biggest symptom of that condition. And like the Still's disease associated with this, obviously that happens in adults as well. So you would like, in case you were thinking about a rash with Gia, because Gia also does have a rash, but it's not the same one. And then childhood cancers. So this is not really tested on that often. ALL is quite commonly tested on, especially in the context of like children with Down syndrome or people with Down syndrome will have a higher risk of developing ALL. And it is the most common anyway, like the most common cancer, and the peak incidence is about 2 to 3 years of age. And you're just looking for signs of bone marrow failure, like I kind of already went through. So bleeding, anemia, and maybe even like an infection that they wouldn't normally get, or and yeah, like I said, Down syndrome have a higher risk of ALL. So briefly kind of covering the other cancers that can come up. So a neuroblastoma is basically a cancer that comes from the adrenal medulla. It crosses the midline. That's really important to remember because that's how you differentiate from Wilms tumor, which does not cross the midline. And then in neuroblastoma, kind of think about it as it's the cancer of like the catecholamines. So you've got all this like fight or flight stuff going on, all this sympathetic activity. So it causes like swelling in the eye, and it also causes hypertension, tachycardia, which makes sense. And then you diagnose it with looking at your urinary catecholamines and its metabolites like VMA. And then you can also do an MIBG scan, which is like a nuclear imaging scan that looks at, and it's good at picking up neuroendocrine disorders, not disorders, cancers. And then the way it's managed is via surgery, chemo, and radiotherapy as well. And then nephroblastoma, this came up a lot in past med questions. It arises from renal tissue. It's like an abdominal mass that it can present as, and in kids, it can be like really big abdominal masses. Like you'd be surprised at how big they are. And it can also cause loin pain because of the abdominal mass. But the most common way it presents is with hematuria and like not as big of an abdominal mass, but it might just also be like one episode of hematuria. So always if there is hematuria, that's like an alarming sign in your head. And in a lot of them, they don't even have fever. In Wilms tumor, I think only about 50% of them actually have a fever in their history. And then in terms of imaging, it's like a CT and it has like a mixed like characteristic. It's got like solid bits and like fluidy bits. And the way it's managed is with a nephrectomy. So you'd be removing the kidney or part of the kidney that's infected, not infected, diseased. And then also you give chemotherapy, and the prognosis of it's pretty good. I know that the younger like this gets picked up, the better prognosis you have as well. And then brain tumors in children, well, brain tumors aren't really covered in our syllabus much. The only things I would say to remember are that medulloblastoma is the most common malignant brain tumor, but astrocytoma is the most common brain tumor overall, but not all of it is malignant necessarily. And PassMed has this really nice table where it's got all the brain tumors and then lots of their histopathology, and you can learn that if you want, but I've not seen a question on it in any of the UCL banks for 5th year. Like the histopathology, there may be a question on brain tumors, but not necessarily like what type of cell is seen. And then this is just a chart. I don't think it's worth your time. This is good. You're just looking at all the like symptoms, so good ones to ask for any kind of blood cancers are like tiredness, anorexia, if they've been looking pale, bone pain, any stomach discomfort, like hepatosplenomegaly may not present as pain. It just might feel like a bit different to what they've been used to in the past. And then also dizziness, like it's a common way for anemia to present. So just keep these things in the back of your mind. And then referral guidelines for cancer, you certainly don't have to learn these off by heart. But I'd say remember the leukemia ones for sure. So any unexplained petechiae or hepatosplenomegaly, they need an immediate specialist assessment and a very urgent full blood count. This is like the only time I've seen very urgent being used, and it's basically within 48 hours. They need a full blood count if they've got any of these like symptoms or issues going on with them. And that's for leukemia. And then lymphoma, they need a very urgent referral for non-Hodgkin's or Hodgkin's lymphoma if they've had any kind of lymph node swelling that's been unexplained or splenomegaly. And then neuroblastoma, very urgent referral if there's been like an abdominal mass or like an enlarged abdominal organ. And then retinoblastoma, that's you check that when the baby was quite small in like their baby checks, so they will do the eye reflex and that'd be absent. When I did my pediatric placement in Luton, you get to do the baby check, so it's really cool to do that. I'm glad I didn't pick any of this up though. And then nephroblastoma, so like I said, unexplained visible hematuria is really important, and it's sometimes kind of neglected, it's forgotten about because everyone remembers this really big mass associated with it. Yeah. And then briefly, other causes of petechial or purpuric rashes. So ITP, so this is basically very similar in children as it is in adults, but the only thing to remember is that ITP in children is usually very benign and self-limiting. You don't need to give them steroids or any medication really. And then HSP, so just be thinking about the triad of like a purpuric rash, abdo pain and joint pain, and then you'd want to kind of do a urine dip because that should be quite easy to do to check for hematuria and proteinuria. And there's also involvement of intussusception depending on like the age that they present with HSP. And then really quickly, just going through BLS, because not everybody gets like pediatric BLS training. So I'm just gonna, I think I'm gonna start with the normal pediatric one and then we'll briefly do neonates because you'd never be expected to do neonates. I doubt you'd be expected to do pediatric BLS as well in like an OSCE station, but it's worth knowing. So it is similar to adults, but there are a few differences. So you still do your normal like check for danger, then approach, and then you'd see if the patient is responsive, then you'd shout for help. You'd open their airway, and this time instead of putting them in like a head tilt chin lift, you'd put them in like what we call this a slight past neutral position. So their head is kind of just looking straight up instead of their chin being up to the sky. Their head's kind of straight, and it's called a neutral position, a bit past a neutral position. And then you would want to see if they're breathing and you'd see for chest fall and rise. And then the first thing you do, it's really important. The rescue breaths are way more important in pediatric BLS, both neonatal and the normal pediatric one, than compressions. That's the biggest difference when it comes to adult versus kids. And you'd give 5 rescue breaths and there's still no signs of life, and then you'd start your compressions. And in children, if they're like a young child, you can use one hand to give compressions, and then you can like hold your shoulder as you give the compressions. You don't have to use 2 hands because that can be quite harsh on them. Unless they're like a teenager or they basically look like an adult, then you can use 2 hands and proceed as normal regardless of their age. Yeah, so it's 15 chest compressions this time, and then 2 rescue breaths, and then 15 chest compressions, and you carry on till like somebody comes for help. So the biggest difference between pediatrics versus adult is first the position that you do the head in. So it's not a head tilt chin lift, it's just a little bit more like flat compared to that. And then you'd give 5 rescue breaths immediately when you see that they're not breathing properly. Then you'd see if there's still no signs of life, then you'd start your 15 chest compressions, then you'd give your 2 rescue breaths, and you'd carry on in cycles of 15 to 2. In terms of neonates, it's really important to first dry the baby that comes up in SBAs and start the clock. Because the reason you start the clock is because the APGAR score, which is your, I think it looks at like their reflexes, their color, and I can't remember off the top of my head right now, but it looks at some of those things. You can definitely find it on PassMed though. And you want to assess the APGAR score at certain time intervals within 10 minutes to see if it's above 7, because above 7 is considered normal. Whereas about 0 or 3 or under 7, you'd be like really worried. And then if the baby is not breathing or gasping for air, you'd give them 5 rescue breaths. So it's similar to the normal pediatric one. Just make sure that their lungs are properly inflated. So it's really important to look for that chest rise. and then you'd give oxygen and ECG monitoring, and then you'd only start attempting chest compressions once the airway is like good, or once you can actually see the chest rising and falling. Because if you can't, that means that the breathing isn't intact, and there's no point trying to do compressions because their breathing is not going to sustain them anyway. This time the ratio of chest compressions are 3 to 1, and the way you give it is like your thumb, like imagine the baby's between you like that, and then your thumbs are at the sternum, like, or just underneath, and then you'd give it like that, and you'd keep reassessing their pulse. You'd never be doing this alone. This would be like a team effort. But yeah, that's the end of my section. I would appreciate any feedback, or if you have any questions, would like me to go through anything again, please let me know, or anything you'd want in next week's session as well. Yeah, I hope that was useful for you guys. If you just like, even if you have questions about 5th year in general, I don't mind.